important things in the history, besides demographics and contact details, which are required for the follow-up, are the obstetric history and the family history. Prior treatment history, if there is any, is important, and any other apparent abnormalities or problems should be asked, which are pointed by the parents in the examination room. Now, the examination, it begins not with the foot; it begins with the rest of the musculoskeletal system. Besides musculoskeletal system, if there are obvious markers, then you must examine the chest, the CVS, and rest of the systems. Now, as far as the musculoskeletal system is concerned, you must systematically move from spine to the lower limbs. As far as spine is concerned, please check for sores or hair, etc., to indicate spinal bifida or any curvature abnormalities. In hips, look for a dysplastic hip. Do neurological examination if required, or if the child is too small, ask parents about vision impairment, intellectual impairment, or developmental delays, which will tell you things about diagnosis. And in the last, check for the upper and lower extremities for all joints for full range of motion, contractures, and muscle tone. Right? Be systematic in your examination. Now, as far as the local examination is concerned, as was pointed out by Dr. Jha, it has to proceed in this fashion, and only in this fashion. It begins with inspection, palpation, followed by deformity and range of motion, measurements, and neurology whenever applicable. Now, it all starts with inspection, and you start inspection as soon as the patient walks in, if he is in the walking age. If the patient is brought into the clinic by the parents, you must inspect the patient on the lap of the mother, making him comfortable, or on the examination table, wherever the child is not present. The inspection has to be done from all sides. That means dorsolaterally, posteriorly, medially, and from the plantar aspect. Right? Now, when a case of a clubfoot, idiopathic clubfoot will come to you, you will generally see the patient, you will start examination from the dorsolateral aspect. Now, from the dorsolateral aspect, you can see that the foot is bean-shaped, a concave inner border, a convex outer border, atrophied skin is present with multiple creases over here, right? Then the lateral malleolus, if you see posteriorly, the lateral malleolus is more prominent as compared to the medial malleolus. The heel is small and inconspicuous. It is varicized. It is lying in the varus, right? And above over here, the tendoachilles is there, which is small and contracted. On the medial border is concave. You can see cavus. You will see two clefts, two creases, one deep crease over here and another deep crease just above the posterior aspect of the heel. Now, the presence of these creases are very much pathognomic of idiopathic clubfoot. Therefore, you must see for these creases. If the patient is in walking age, you must see for callosity. Now, inspection is followed by palpation. Now, irrespective of the organ what you are palpating, it must be systematic, and temperature, tenderness, swelling, and callosity and alignment must be seen. Now, where to see? The points which are to be palpated, they include bony prominences, including the malleoli, the lateral head of the talus, the borders, the heel, the tendons which are contracted like tendoachilles, and sometimes you will also palpate for the tendons of tibialis anterior and tibialis posterior. And very important, you must see the extent of correction while you are palpating. This is followed by deformity and range of motion. We already know that a clubfoot has a deformity of equinus at the ankle joint, right? You can see the equinus. At subtalar joint, it is varus, right? If you see posteriorly, the heel is inverted. At midfoot, there is adduction. And at forefoot, there is pronation, right? Now, how does pronation occur? Is that the hindfoot, it lies in supination. The forefoot is in relative pronation. And because forefoot is in relative pronation, that is why the first metatarsal, it falls down as compared to the rest of the metatarsals, resulting in cave. So this results in the famous acronym of cave, that is cavus, adduction, varus, and equinus, right? So range of motion, we know the deformities. So deformity means that the movement in the opposite side is not present. So if there is plantar flexion at the ankle and it is deformed in plantar flexion, that means dorsiflexion will be absent, right? Similarly, there will be no valgus at the or no eversion at the subtalar joint. There will be no abduction at the midfoot, and there will be no supination at the forefoot, right? So all these deformities are present, and that is why correction is not fully there, and that is why it is called a idiopathic clubfoot. Now, it makes sense over here that when the child is in walking age, you can see the movements while making the child walk, and while making the child walk and stand on toes as well as on heels, right? Measurements. Now, measurements are important. They may not be very important in a small child where there is a idiopathic clubfoot, but they may become important when the child is suffering from a secondary clubfoot, right? When it is a neurological or a syndromic clubfoot. So do not forget to measure the leg, the whole of the lower limb, ipsilateral as well as contralateral, the calf girth, and obviously the foot from back of heel to the tip of great toe. Now, as far as imaging is concerned, the imaging is not necessary for making a diagnosis in a case of idiopathic clubfoot, right? Imaging is done only in special conditions, right? One of the condition is failure of a non-operative treatment, right? When the non-operative treatment or conservative treatment has failed, we want to do some operative intervention, and that is where you want to take an X-ray so that you confirm the residual deformity and their magnitude. Second, a recurrent deformity, right? Again, before planning the operative management. Third, you have to take an X-ray after after the correction of deformity by operative management to see whether these deformities have been fully corrected or not. And lastly, you must take the X-rays in an atypical secondary or feet which are unusually resistant to non-operative standard treatment, that is consequence treatment, right? So what X-rays do you take in these children, right? In non-ambulatory children, you take an anteroposterior view and a lateral view in stress loss affection. In an ambulatory child, you have to take an anteroposterior view and a lateral view in a standing position. Again, as the discussion was being generated, for an older child, you can take a step and make the child stand so that his foot height is comparable to the height of the extremity. Now, before we see the X-rays, we must know the ossification centers. Now, the ossification centers for the calcaneus, the talus and cuboid, and the metatarsal shafts, they generally appear before birth. You can see in this X-ray, this is lateral, this is the ossification center for calcaneus, this is medial, ossification center for talus. Cuboid has still not appeared because generally the ossification center appearance in a clubfoot deformity is delayed. Over here, the cuboid has also appeared. Out of the tarsus, navicular is the last to appear, which appears after around 3 to 4 years. You can see in this child, talus, calcaneus, cuboid, and navicular. So this child is at least 3 to 4 years of age, right? So once you know these ossification centers, then we can proceed with the rest of the imaging. Now, what do we see on an imaging, right? On an AP view, you see the talocalcanean relationship, right? In a lateral view also, talocalcanean relationship is the most important angle, right? Besides, there are several other angles which are described. I've taken which are important. The relationship between the talus and the first metatarsal, right? If the navicular is present, then how much navicular is covering the talar head, that should be seen. On a lateral view, besides talocalcanean relationship, we can include the tibiocalcanean angle, right? And lastly, there is a talocalcanean index, which is generally asked in the exams. It is also called Kite's index, which is addition of the AP and lateral kite angles. It should be more than 40 degrees in corrected clubfoot. So these are the normal values. A AP talocalcanean angle should be 32 for 55 degrees. A lateral talocalcanean 25 to 50 degrees. A talo first metatarsal angle is generally 5 to 15 degrees. If the first metatarsal is falling medial to the talus, the angle goes into negative, that is less than 0 degree. Similarly, a tibiocalcanean angle normally should be 10 to 40 degrees. However, when it is in equinus, that means dorsiflexion is not present, it again goes into negative. On the whole, the principle is that there is parallelism is seen in between talus and calcaneus in both views in a case of clubfoot. Just look at these long axes. This is talus, this is calcaneus. They do not cross each other. This is a case of clubfoot. Whereas in this case, which is normal, right? This is long axis of the talus, this is long axis of the calcaneus. They cross each other. Similarly, in an AP view, right, they are divergent, right? So these divergent views are open scissors, whereas these convergent views or parallel views are closed scissors. So closed scissoring, it happens in club foot, and open scissoring, it happens in a normal foot. So diagnosis. So once you have examined and you have imaged the foot, the next question which will be asked in the exam will be, what is your diagnosis, right? Or when you have said your diagnosis, they may ask you what is a idiopathic club foot or a CTEV, right? So there are many prevalent definitions. So this is a definition which is simple and easy to remember, and it covers almost all aspects of idiopathic club foot. That is the congenital cavus, adductus, varus, and equinus. That is a cave deformity of the foot which is not completely corrected passively, right? So it is non-controversial definition, and it covers all aspects of a idiopathic club foot. So once you have defined, you have told the examiner that what is your diagnosis, you have also defined it. Now the examiner will definitely ask you, why do you call it an idiopathic club foot and why don't you call it any other club foot? Now the answer to this question is relative, but you have to answer this question objectively. So the objective answer should be that it is a characteristic bean-shaped deformity in an otherwise normal child. Otherwise normal is important over here, because otherwise normal means that the child is not suffering from any neurological or syndromic condition. That means you have ruled out a secondary club foot. So this becomes a idiopathic club foot. It is present since birth. The history will tell you. There is a deep medial crease and there is a deep cleft or crease just above the posterior tuberosity of the heel. Now, in a normal foot, you will see that there are several fine creases over here. These several fine creases form because in utero the child is able to dorsiflex the foot and plantarflex the foot. Now, since this is a deformity in plantarflexion, the child was never able to dorsiflex his foot in utero. That is why these stretching marks or these fine creases were never formed in this foot. So this is one of the most important findings which you will find in an idiopathic club foot, which you will not find in an acquired club. Besides that, calf atrophy and hypoplasia of the ipsilateral limb will nail the diagnosis as far as clinically is concerned. So what are the differential diagnoses? I'm sure the examiner is going to ask you this, right? So you have to differentially diagnose your idiopathic club foot from several other conditions, right? Which are based on the cause, like a postural club foot, a metatarsus adductus, atypical club foot, secondary, and skew foot. We'll gradually cover one by one. Now, what is a postural club foot, right? Postural club foot means that it looks like a club foot, but actually it is not a club foot. So actually there is no deformity. You will be able to correct the foot fully. That means you will be able to achieve dorsiflexion, which is much more than 15 degrees, right? Although the foot appears to be a club foot. The foot is normal in shape and size, and there will be no calf atrophy and hypoplasia of the limb. Idiopathic versus metatarsus adductus, right? Now, what is metatarsus adductus? It is basically a condition where the hind foot and midfoot are normal. Yeah, there are no deformities in the hind foot and midfoot. However, the forefoot shows adduction of variable degree, right? So you will be able to see a forefoot adduction, but there is no cavus and there is no equinus deformity when you will examine the foot. Idiopathic versus atypical. Now, this atypical club foot came into picture only once we started doing pauncity. It was defined by pauncity as a short chubby foot with a cocked up great toe, right? With a deep midfoot crease, right? You can see this crease which can be also visible laterally. This complete falling off all the 5 toes is called not cavus. It is called plantaris deformity. Cavus means falling off only the first metatarsal. When all the 5 metatarsals fall, they are called plantaris deformity. And there is severe equinus. According to pauncity, right, this was the pathogenesis of this deformity. So what has happened is that there was a short and chubby foot to begin with, and you applied a plaster, a pauncity cast. Now, instead of holding, the toes disappeared and the foot slipped proximally inside the cast. So that heel reached here instead of sitting here, and that resulted into a fixed severe equinus. The same mechanism results in popping up of the great toe, and once you remove the cast, even after 7 days, what results is an atypical foot. However, controversy exists. Many of us have found an atypical foot to be present even without application of the first cast. Idiopathic versus secondary. Now, secondary feet are very important, right? You have to examine rest of the body and neurology as well as vascularity of the distal limbs to differentiate in between idiopathic and secondary club, right? Now, the common causes are spina bifida. Cerebral palsy has now taken over than PPRP, as PPRP is gradually vanishing, and other neurological deficits like Charcot-Marie-Tooth disease. So you will find telltale marks like a spina bifida, like a spina bifida, like a ulcer, right? In a patient of cerebral palsy, if the child is older, you will find all the telltale signs of spastic cerebral palsy. In syndromic, what comes to us more often is arthrogryposis, a congenital band syndrome, and tibial hemimelia and other syndromes, which you will be able to find out if you have done a good systemic examination, and that is why a good systematic examination is important to rule out a secondary clubfoot. That is why I told you that please do not jump on the diagnosis of idiopathic clubfoot as soon as you get a case, right? Because that will block rest of the mental thoughts. Idiopathic versus skew foot. Now, skew foot is something which is also called a Z foot, where there is varus or forefoot adduction in the forefoot, and there is valgus of the heel in the hindfoot. It is usually iatrogenic. We will go into this later on. Now, sometimes the examiner might ask you what is the pathoanatomy or soft tissue contracture, right? Now, please do not get bowled over in this question because it is too much material to learn, right? So what you do is that you visualize the foot in your mind, right? The deformity of the foot in your mind. Whatever is there on the posterior side, both medially as well as lateral, is contracted, right? So what is present on the posterior side? Tendoachilles, right? The capsule of the ankle joint, the capsule of the subtalar joint, the calcaneofibular ligament. On the medial side, the deltoid ligament, the spring ligament, the capsule of the talonavicular joint, and on medial side again, tibialis posterior, FDL, flexor distorum longus and flexor hallucis longus, and where they cross over, they form a Henry's knot, right? So please do not get bowled over by this, right? Now coming to the plantar surface, right? What will be contracted is whatever is in between the talus and calcaneum, right? That is talocalcanean interosseous ligament, a bifurcate Y ligament, plantar aponeurosis. So therefore, what I want to say is that even if you do not remember all the structures, it does not matter, right? If you remember the deformity in your mind, you will be able to answer logically. So a logical answer is more important than an absurd answer. Classification. Now, classification actually does not matter. We usually classify it into a severe or rigid foot or a mild and supple foot, right? By definition, a short and stubby foot, which is rigid on manipulation with a short first metatarsal and cocked up great toe, is called a rigid foot, right? So whenever you are examining a patient of idiopathic club foot, please try to correct the deformity, manipulate and correct the deformity gently, right? So if it is resistant, then most likely with these features, then most likely it's a rigid foot. On the other hand, if it is a longer, less rigid foot, supple, and it is pliable to manipulate, and great toe is normal, it is more commonly it will be a supple or mild variety. Now, besides classification, you have to evaluate. Whereas classification tells us the cause and the treatment stage, evaluation will objectively tell us what is the suppleness, right? Not only that, it will also tell us the effectiveness of treatment, and it predicts the time for treatment, right? So one of the most common methods which is available to us for evaluation is Pirani's method. Those of us who run a CTV clinic or those of us who treat CTV, we know how to do Pirani's. It is a very easy method, quick method, very objective, right? And very less intra-observer differences. So there are the Pirani, the original Pirani, it started with 10 points, but what we practice in the clinic are just 6 points. 3 hindfoot contracture points and 3 midfoot contracture points, right? Let's go consecutively. So this is a curved lateral border. What you place is a rigid object along the lateral border of the foot without doing any correction. This is the only parameter which is done without producing a passive correction, right? So when whole of the foot is aligning with this rigid object, it is 0. When only the proximal part of the foot is aligning with it, and the forefoot is not aligning with this rigid object, it is 1. So the medial crease, right? There is absence of crease on full correction. There is partial appearance of the crease. There is full deep crease present over here. So this is 1, this is 0.5, this is 0. Similarly, a posterior uh, uh, crease, right? You can see these multiple creases over here. That single deep crease is not there. So this is 0, whereas a single deep crease is present over here. So this is 1. The reducibility of the lateral head, right? You will see with the help of one toe while you're abducting the rest of the foot, right? If it gets reduced fully, it is 0. And if it doesn't get reduced at all, this is the uncovered head of the lateral talus, uncovered lateral part of the head of the talus, which is not reduced completely. So this is 1. This is getting reduced completely. This is 0. Empty heel. Empty heel, you will palpate the posterior tuberosity of the heel in full correction. If you are able to palpate the heel as in the other foot, it becomes 0. If you are unable to palpate it as a soft spot, it becomes 1. Rigid equinus. Rigid equinus is usually palpated with the knee in extension and ideally should be seen from the lateral side. So with knee in extension, if you are able to extend or dorsiflex beyond 90, beyond neutral, it becomes 0. If you are unable to do it, it becomes 1. So this is in short the Pirani's method. There are other evaluation methods more difficult, right, but more objective. They can also be utilized. One of them is the Dimiglio method, right? So generally speaking, in a small child, we use a Pirani's method. In a bigger child who is able to walk, we use the Dimiglio method. So this is generalization. Now, once we have classified and we have also evaluated the case, the next thing is how will you manage, right? So management will differ in a neonate as well as in a non-walking child. So management, all of us know it starts with paucity, right? Because it is the method which has low relapse, it is quicker, it has reduced the requirement of surgery in clubfoot to almost none. We are not doing any more surgery in clubfoot now, and it is effective even in neglected resistant syndrome. But the treatment starts with counseling. So always say this in the exam, that you have to do parent counseling. You have to tell the parents about the next child if they are planning the next childbirth, about chances of getting a clubfoot in the next child, right? And before you send him for treatment, you have to manipulate, right? While you are examining and palpating, you have to manipulate and see its reducibility, right? So the serial class, it starts as soon as the patient presents to the clinic. Frequency is generally 7 days, and the casts are applied till we achieve a abduction of 60 to 70 degrees. A PCT, that is percutaneous sternotomy, is usually done after we have completely corrected the midfoot score, and the hindfoot score is generally less than or equal to 1. So understanding paucity, right? Now, if you look at this figure, right? So this figure shows you that the hindfoot is in supination, the forefoot is in pronation, and because the forefoot is in pronation, that is why the first ray drops. Now imagine if you pronate this foot, right? If you consider whole foot as supinated and you pronate the whole foot, you will not be correcting the foot. You will be just exaggerating the case, because the more you will pull this metatarsals up, the fifth metatarsal up, that is pronate, the more the first metatarsal will go down. So the first step in paucity method is elevation of the first metatarsal, right? That is correction of the pronation of the forefoot. That is, you supinate the forefoot. So although it seems that you are exaggerating the deformity, but actually you are bringing the first metatarsal in line with the rest of the metatarsals. So number one, never pronate, because that will increase cavus. Not only it will increase cavus, it will lock the forefoot in a deformity. You will not be able to bring that foot out of that deformity. The second point, once the first metatarsal lies at the level of rest of the metatarsals, now you can abduct gradually, placing your thumb on the lateral head of the talus. So use lateral head of talus as a fulcrum and abduct this foot around this lateral head of the talus. Now you will see that as soon as you have started to abduct the forefoot, the heel automatically goes into valgus. You don't have to do anything for the heel. So the second point is the heel should never be held, right? If you will hold the heel in your hand, you will be just abducting this, and you will block the free movement of valgus of the heel, by which the heel will correct automatically. So there are two no's in it, right? Never pronate and never hold the heel. So this is what the lifting of the first metatarsal was called the golden or the magic move, right? We have already discussed it. Once we have done that, you have to just gradually abduct it till you achieve abduction of 60 to 70 degrees. This is followed by a percutaneous knotting, right? So I'm not going into detail because you have already read about quantities management, but this is important. These steps are important in the examination, right? So PCT is done to achieve a dorsiflexion of around 10 to 15 degrees. Now bracing. The bracing has to be done with the help of a foot abduction bar, or which is also called a Steenbeck brace. It is applied 23 hours a day initially for the first 3 months, setting 1 hour for cleaning, right? After 3 months, the foot abduction bar is applied only during sleeping time for a minimum, and it is continued for a minimum of 4 years. There are no walking shoes which are advised, right? So it is important to understand that the bracing confines only, in idiopathic club foot, confines only to a foot abduction bar, nothing else, right? So some questions may be asked regarding the casting technique. Why a long leg cast? Why not a short leg cast? Yes, a long leg cast is necessary because the required external rotation and abduction, which is required in the Ponsonby method, can only be held by a above knee long leg cast, right? If you will be applying a short leg cast, although there are papers now on that also, you will be defeating your purpose of achieving this much abduction, right? Second, it prevents cast slippage, and the knee position is definitely 90 degree until unless it is some other conditions they dictate they differ the position of the knee. Now, a word on difference between Dennis Brown splint. Many of you might not have seen a Steenbeck brace and a Dennis Brown splint, and you might be confusing in between the two. So a Dennis Brown splint is nothing but a crossbar which with foot plates at 20 degrees. The principle is that the kicking action of the knee will stretch the tendinoculus, which will result in the correction of deformity. So originally, a Dennis Brown splint was used for correction of the deformity as well as for holding the deformity. Now the difference over here is that at Steenbeck brace, the crossbar is there, right, which is not straight, which is curved, right, and the foot plates are at 60 to 70 degree of abduction, which is necessary to hold the foot in that, because we achieved that in the last class, right? The abduction prevents the relapse of the deformity, and that is why it is very important. Now this Steenbeck brace is never used for correction of the deformity. It is just used to hold the deformity, right? So that must be clear in the whenever you speak the differences. The potential complications are obviously iatrogenic, right? One of the common deformities, one of the common complications is rocker bottom foot. What happens is that you are just dorsiflexing this forefoot, right? And there are unending soft tissue structures over here. So what you do is that you produce a break at the midfoot, right? And it becomes a boat-shaped, a convex medial border foot instead of a normal arched foot, right? Other complications are obviously tight plasters, right? Sores, pain because of trauma and callosities, calf atrophy because of repeated plasters, and sometimes stress fractures. Now it is imperative over here to mention a word about Kite's method, right? Now this Kite's method, it was the celebrated method before actually Ponsonby came, right? But the crux of the difference is that the fulcrum of the correction was at the calcaneocuboid joint, right? In Ponsonby method, the fulcrum is the lateral part of the head of the talus. In Kite, it is the calcaneocuboid joint. When the fulcrum is at calcaneocuboid joint, you hold the heel as it is held in this diagram. And once you are holding the heel, you block the valgization of the heel with the abduction of the forefoot. So that was the holding of the heel was called Kite's arrow. So anyway, so we are not using Kite's method anymore now because of all these problems, and that is why Ponsonby method is being used. The other equally successful method is French functional physiotherapy method, which is not practiced in India, probably because it is difficult for us to do manipulation daily at home. Temporarily, in between the functional physiotherapy, adhesive taping is done so as to hold the deformity correction. Now there are few nomenclatures, that is, these are the classifications which are based on the treatment stage of the clubfoot, right? According to that, it might be a persistent deformity. That means it was never fully corrected. A relapsed and recurrent clubfoot is one where the deformity recurs or worsens after correction, right? A resistant clubfoot should ideally be that which does not get corrected by a standard method of correction. However, it has been defined by Ponseti as even after application of 3 serial Ponseti castings, when you do not see improvement on scoring, it is labeled a resistant clubfoot. Now, there might be some controversy on the nomenclatures, but these are the most acceptable definitions. A neglected clubfoot is one when the treatment is started after the child has become ambulatory. In other words, it can also be a clubfoot. A neglected clubfoot is also an untreated clubfoot in an older child. And lastly, a complex clubfoot. Whenever a clubfoot is treated with methods other than Ponseti, they may have residual deformities and scarrings, and these are called complex clubfoot. Now, although I have defined all these, there might be controversies in this, and many different authors might tend to differ. Many different examiners they might tend to differ, right? So let's do a quick go through a neglected clubfoot, right? Now, this child is a bigger child. This child will come to you walking, so you start examination with the gait, right? Besides asking demographics and family history, ops history, you have to examine the child systematically. So always start from the spine, hips, do examine the knees, the contralateral limb, and always proceed in that. See the severity of the deformity. The child might be painful on walking because now he has developed a callosity. Now, most important thing is that the parents have brought this child to you now at this stage is because he's unable to wear a normal footwear, and that leads to ostracism, right? And that is the reason why this child is now brought. Besides that, the parents might also think about thin legs, short feet, and you must ask about the previous attempts of treatment, if any. Now, imaging, as usual, is a must in a neglected foot, right? As I told you that there will be parallelism in between talus and calcaneum, right? So sometimes you are able to get a good view in a neglected foot, but sometimes the foot is uncorrectable. You might be just doing an X-ray just for the sake of record. Differential diagnosis is important in neglected clubfoot. Secondary causes have to be ruled out. How do you rule out? By presence of scar, that is a telltale treatment effect, ulcer, when the child is walking, or when the child has spina bifida, neurological problems, sensory problems, might develop an ulcer. Neurological examination in these children is a must. So you have to go systematically, and you must do imaging in this child. Now, I just included this image because the parents might be telling you that we did not receive any treatment. But when you see such an image with a flat top talus, you know already that the child was treated somewhere, treated wrongly somewhere. Right? Now, treatment options. So once the treatment options for a neglected foot till at least the age of 4 years, right, has to be conservative. Ponseti treats even children even at this age, and we have treated even older children as old as 10 years with Ponseti techniques successfully. But there might be some residual deformities which might remain after conservative management in such an old child. For that, you may have to do a la carte approach surgery, right? If there is some degree of equinus present, you may have to do a percutaneous sternotomy or a semi-open sternotomy. When you think that it is not amenable to a percutaneous sternotomy and the posterior capsulotomy is done, you must go for the formal open tibialis tendinous lengthening plus minus posterior capsulotomy. Then the chaos part is more. You might have to release the plantar fascia, the Stangler's procedure, and sometimes when there is over supination, you might have to do a tibialis anterior tendon transfer, right? So if tibialis anterior is overactive, it pulls the forefoot into supination, keeps the hindfoot into varus. So if you redistribute the power, that is, if you transfer this power laterally, the excessive pulling into supination will be prevented. The other treatment options in a neglected clubfoot are extensive soft tissue release, as described by PMR, as described by Turco, that is posteromedial release, right? What you do is in posteromedial release is that you release or lengthen everything which is present medially and posteriorly, right? And then you place the navicular and correct acquisition to the talus, fix it to the K-wire, and that is a posteromedial release. A complete subtalar release is more anatomical. It is more amenable with the Ponseti technique, right? So what you do is that you not only release medially and posteriorly, you also release, as I told you in the beginning, that the structures on the lateral side are also contracted. So you release medially, posteriorly, laterally, and on the subtalar aspect, right? And then the navicular is placed in correct position to the talus. The CSTR was described in my clip.
Dr. Alok Sood, can you please make it
Yeah.
slightly short because we are running out of time.
All right. Okay. So last two slides. So other are bony procedures, right? That the lateral column is longer, the medial column is shorter. So you shorten the lateral column, right? You shorten the lateral column. Sometimes you might have to combine the shortening of the lateral column with lengthening of the medial column. And sometimes when there is only one deformity present, you might have to do just osteotomy of the heel. And a word about external fixators, right? So when you know how to apply external fixator, you distract posteriorly, medially, and postomedially, and sometimes combined with the osteotomy will produce a good correction. Similarly, by just fixator, say external fixator producing good correction. Triple arthrodesis is not done anymore because usually we are able to solve the problems. Other procedures include supramalleolar osteotomy and telectomy, right? So summary is that in supination you can do tibialis anterior transfer. In varus, you can do lateral column shortening. In intorsion, supramalleolar osteotomy. All deformities can be corrected by external fixators. This is theoretical. Thank you very much.